Good morning, facilitators. Good morning, colleagues. You are welcome to today's presentation. I will be taking practice question 2, November 2022. Sorry. The question says, a clinical scenario of increased mortality of patients presenting with upper GI bleeding in your hospital. What will you do? Mention the steps you will take. Mention how you will take data in this condition. List teams involved. List headings of your reports to the hospital management. So these are the response. What will you do? I would like to do clinical audit on the situation. That's increased mortality in patients presenting with upper GI bleeding. I would like to frame it as the investigation of increased mortality in our facility. Mention the step you will take. I will take these 6 steps of clinical audit. I will identify the problem. I will define standards. I will take data. I will do analysis and I recommend changes. Then I will implement the changes and then I will audit the situation. So to expatiate more, identification of the problems, I would like to do systemic root cause analysis to identify underlying causes and contributors to the increased mortality rate. I may use either fishbone diagram tool, or I will use the 5 whys technique to identify the root cause of the problems. And this may involve reviewing clinical protocols, staff level, equipment available, and coordinating care process. Definition of the standards, meaning I'm going into the clinical audit proper. What are those standards that are put in place to manage cases of upper GI bleeding? I will try and scavenge for the evidence-based guidelines regarding the management of upper GI bleeding. I will try and assemble multidisciplinary teams involving gastroenterologists, hematologists, intensivists, nursing staff, especially those that have a training in gastroenterology, quality improvement specialists, hospital administrators, to identify the issues comprehensively regarding why we are having increased mortality. And these staff, they are the one to work. They will be given a clear terms of reference, including timeline. And then for the process proper, I may likely involve ethical clearance committee of the hospital so that they give us go ahead to continue with the auditing process. I will take data. I will expatiate more subsequently because the next question asks us how we will take the data. And then I will do data analysis based on the outcome. And then I will make recommendations, or the team will make recommendations. And then subsequently, we'll implement the recommendations for a certain period of time. We'll say, this is how the implementation, we notice this, and that. Is it that the patient are having poor health-seeking behavior, or there is delay between triage physicians to the specialist physician? Or is there a problem regarding interventions? Or is there a problem regarding blood supply, or the medical therapy, or even the surgical therapy of the upper GI bleeding? Then we recommend that these are the changes that should be implemented, and the committee will now audit and then start implementing recommend the implementation, and then the units involved are encouraged to abide by the new changes. And then after a certain period, we audit the situation again. The next question said, mention how you will take data in this condition. First of all, I will take patient data. I will gather information of patients with upper GI bleeding, including their demographics, comorbidities, presenting symptoms, vital signs at presentation, and then the initial laboratory results and the imaging findings. The timeline of events from onset of symptoms to the initiation of treatment, including any delay or changes encountered during the care process. I would like to take data on outcome tracking, monitor and record patient outcome, including survival, need for intervention, length of hospital stay, and then complications that patient developed or organ failure. I will now analyze the outcome of the patient, whether they have mortality or they are discharged from the hospital or any other possible outcome. I will now look at the risk factor, identify the document, and I would identify and document specific risk factors associated with increased mortality, such as hemodynamic instability, coagulopathy, presence of and grading of the varices, and underlying liver disease. I will evaluate the impact of comorbidity with regard to mortality, the various medication patients are using, and prior history of upper GI bleeding. I'll also take data on the process. I'll assess the timeliness and appropriateness of intervention, including the resuscitation at emergency room, endoscopic evaluation, and administration of specific therapy, either medical or surgical. I will document any deviation from established protocol or best practices as earlier recommended by the auditing team. I will take data on quality metrics. I will establish quality of metrics related to the care of patients with upper GI bleeding, such as time to endoscopy, adequacy of resuscitation, utilization of evidence-based therapy. I will also audit and record and resource staff and resource allocation. I'll evaluate the level of staffing in the facility, availability of specialized services such as intervention radiologists and operating rooms, and then access to blood products. Also implement system for real-time monitoring for patients with upper GI bleeding, so that I will monitor them probably using the electronic system. And then I will compare the hospital performance with regard to managing upper GI bleeding and any other standard hospital internationally or within the country. These teams involved.
Somebody's background, please. Okay.
The teams involved in addressing the issue of increased mortality of patients presenting with upper GI bleeding includes gastroenterology team, which may be the leading team, the hematology team, the intensivist, nursing staff, pharmacy unit, intervention radiologist, and the quality improvement and patient safety team like Servicom, and then the hospital administration and the representative of the management. List headings of your report to the hospital. After finishing the report, the headings that I will use to convey my report to the hospital will include root cause analysis, the introduction and background, then the root cause analysis and findings, where I will summarize the identified factors contributing to the increased mortality in upper GI bleeding cases. Then proposed interventions and protocol outlined during the preparatory sessions, outlining the evidence-based intervention and protocol to standard and optimize care for this patient. Then the data analysis and trend. I'll present the data analysis results, including mortality rate, complication, and adherence to the best practices. And the quality improvement initiatives and outcome. I will mention that, and then I'll conclude the report. Thank you. I don't know, should I go ahead to do small overview of clinical audit?
Go ahead, Dr. Dana.
Okay. The definition and importance of clinical audit. Clinical audit is a quality improvement cycle that measures healthcare effectiveness against agreed standards. It is part of clinical governance, ensuring patients receive the best practice, best quality care. These are the benefits: improves quality and efficiency of patient care, identify and measure areas at risk, create a culture of transparency and quality improvement, facilitates professional development, and allow health professionals to stay updated with evidence-based practice. One have the types of clinical audit. It could be either prospective or retrospective. This is with regard to the timing. And then with regard to the process of care, could be classified into structure of care, process of care, and outcome of care. Ethics issue in clinical audits. All audits may require consideration of ethics and scientific issues. 3 levels of ethics review: the safety and quality, and then the clinical governance unit may be involved. Full health resource ethics committee review and proposal may need to review the proposal of the committee. Although some may say that if the audit is for internal consumption, there may not need for ethical committee. However, we may not know what will happen at the end of the process. We may like to publish the data either locally or internationally. So it is recommended before any clinical audit at the preparatory level, after identifying the process before data collection, a full proposal should be sent to the health ethical committee. Then we have to format the question for the audit, choose a suitable name that will give a glaring glaring information about the process. You may need to take data, ensure data variables cover all objectives, use data entry package, and then summarize the data covering key outcomes. The standards is a discussion of the result. Usually the standard is to present at the local or institutional clinical governance meeting, and sometimes we can use it to publish it in a journal, hospital report, conferences, guidelines of educational guidelines. There are some similarities and differences between clinical audit and research. Sorry for the typographical error. The main difference is itemized in the table, in this table. The variables we looked at, what are the focus for clinical audit? It is actually service improvement, while for the research is not addition of knowledge. The output in clinical audit is reports, while the output in research is publication. Minimal funding may be required in clinical audit, and grants may be needed for the research process. Next step of clinical audit is to repeat audit and repeat again, while for research is new study. The target audience for clinical audit usually are internal institutions and the stakeholders in this institution, while for the research is usually global community. The impact for clinical audit is change at workplace, while the impact for the research is for promotion and other benefits. Thank you.
Thank you very much, Dr. Alhatu, for this wonderful presentation. It's really a very good one, and the time management is very good. So thank you very much. We appreciate. You know, it's one of the areas that actually we need to learn more. Thank you very much. I think the floor is open for comments, clarifications before we read out the chat. I think before then, I'll start to read out what is posted in the group. Dr. Ejiro Guinea said, General Surgeon should be part of this team. That we mentioned a lot of stakeholders involved in the team. He believed General Surgeon should also part of the team. And Dr. Agu said he have answers to his question, but he could not have met slides. So I don't know, maybe Chief Christabel may help whether she give permission for him to present like that. Somebody also thank you for this lucid presentation. So the floor is still open. Dr. Ajibola Sanders said he's also ready with his slides. Dr. Dalhat, I have a question, please. Those headings that someone has to report to the hospital management, are they fixed, or that you start with introduction, as you said, then the reports, and subsequently the suggestions and interventions that should be done? Or maybe sometimes depends on the topic in place. I don't know, just need more clarification, please. Thank you.
Well, thank you, Dr. Hell. Actually, I've not seen it anywhere. I just sit down. You can see that I was trying to actually change it because I was in heads while trying to prepare this slide. I just thought of it and then I just designed it that way, but I've not seen it anywhere actually. Thank you.
By the way, our seniors are here, and as I said, in this audit of a team, we need more input from our seniors. Thank you, but I really appreciate that. Thanks.
Yeah.
Yes, ma'am.
And let me just make some comment then. When it comes to clinical audit, we have the queen of clinical audit in class and we have the king of clinical audit in class. They know themselves. So I'll just say some things. I noticed that, by the way, our dear Chief Cookie, she's a clinical audit. She's good at it. Then Chief Chitu is good at it too. So they're the king and queen I was referring to. So let me just say something. I noticed when he was answering the question, it was really everywhere. Dr. Dahato, thank you so much. It was quite a lucid presentation. Showed you did the research. But once they give you a clinical audit question, you choose something you need to do your audit on. Is it a structure? Is it a process? Most time it's between structure and process. They already give you the outcome. So you're not going to audit the outcome anymore. So is it the process? Is it the structure you're going to audit? Structure has to do with manpower, things on ground, the machineries, the manpower and all of that. Why process? It has to do with the time, the process on getting things done, the timing, the duration, the processes, how do you take samples, who sterilize what, the process itself, durations, that's where, so most times they usually advise, and Chief Cookie loves structure. I think Chief Chitu loves process, but I think I love structure. Structure is easy to process, really. We have manpower issue in our country. So everyone that's going for this exam, look for the one that you can easily defend. Once you see a clinical audit question, ask yourself, which one can I easily speak on? For me, structure is easy. We always have manpower issue, people that have lazy attitude to work. So it's always, you can go around, talking about structure. The person doing it, and then the person done, does the person have this, it requires skill, and the person not updated this or has skill. You understand? Was the person really fact that manpower? People are leaving the country every day. Are they overwhelmed? So now they're not good, they're not preparing the patient properly, or they're not doing properly. For me, structure is easy to easily rattle through. So all those going for exam, go through structure process. Which one is easy for you? So once you see clinical audit question, you choose one. Except they are specific, it's okay. Please audit the process, but rarely to do are they specific. So most times, just choose one that is easy for you to speak on. I don't know if Chief Cookie or Chief Chitu have more to say. The hard way was making it so simple, already.
Thank you, ma'am, for this contribution. Thank you.
You're welcome. Chief Cookie, ma.
Yeah, good morning, everyone. Thank you very much. Yeah, thank you. So good morning to the presenter. You did a good job. So just as Dr. Christabel had said, this is a timed exam. And then even in real life situation, you can't do everything at the same time. One thing you must remember about clinical audit, apart from the definition, there's an objective, and your objective must be SMART. So bearing that in mind, with the acronym, S stands for specific. So you can't do everything at the same time. Measurable. Because if you do too many things, you won't be able to measure. And so even when you have the outcome, you don't know, is it A or B or C that is bringing out this desired outcome, because you were all over the place. And then when you are doing too many things at the same time, you won't be able to achieve any one, you know. And it is time bound. You don't have all the time in the world to carry out an audit, especially one that has to do with mortality. The earlier you finish your clinical audits, come up with your findings and then begin to implement it, the better. You know, and that notwithstanding is to remember the definition of clinical audit. So it's a quality improvement cycle that it measures the effectiveness of healthcare, you know, against the standard quality, and then you take actions to bring your practice to in line with these standards. So at every point in time, you keep comparing yourself and then see where the shortfall is and then trying to make it up. So it's not a one-off thing, you know. So that's why you can't do everything at the same time. So you choose an aspect. So there are steps to clinical audit, you know, and then we now have the components to clinical audit. So the steps to clinical audit are the ones that you had mentioned, you know, plan and prepare, select standard criteria and what have you. But the components is what you are going to apply the steps to. And that is the structure, the process, and the outcome. So the structure involves the man, material, and manpower, you know, that it's on ground. And then the process, the procedures, the practices, you know, all the administrative processes, all those things that involve. And then the outcome is the effects, you know, of your processes and structures in coming to bear on the practice itself, you know. So any of these should be audited. So that is where you place your specific criteria on, also as in what you choose, and then you now take your steps according to that. So if you are conducting a clinical audit on upper GI bleeding, you have to look at what are the things that you know, from the heading, the upper. Sorry, can I see the question? Can you scroll to the question? Okay, so a clinical scenario of increased mortality of patients presenting with upper GI bleeding. You know, what will you do? Steps you will take? Yeah. So that's it. So the steps you will take is you prepare and plan. So you have to call for a stakeholders meeting to include the category of healthcare workers that would naturally be involved in managing patients with upper GI bleeding. So usually what I do to make me remember the steps is to divide them into 3 categories. You know, 1, the people who are involved in, you know, taking care of these patients. Then the people who have the authority to implement the changes, and then the patients themselves. So if you divide them into these 3 groups, you remember all the people that are going to be involved. Because clinical audit, must have a power backing it. So whatever you're going to come up with as your policy documents, the head of the hospital or the authorities in the hospital have to implement that. They will be the ones to say, to now bring out like a white paper saying this is what the hospital is going to be doing. So they should, at the end of the day, you must have a protocol, because whatever is not written down and whatever it's not said is not going to be implemented. So any clinical audit must have the HOD, the DCST or the CMAC, the CMD as part of the audit committee. So apart from saying the gastroenterologist, the endoscopist, head of emergency medicine, the nurses also. So it's like teamwork. So each person has complementary skills, not the same set of skills, and they are all coming together. So, and these patients will be managed in the ICU, the head of department of medicine, the head of department of surgery, hematology and blood bank, pharmacy, because they are going to get medications and all, and then the CMAC. Then you choose a title. So this is to determine the factors that contribute to high mortality rates in patients with upper GI bleeding, an example. And then it's like when you are doing your objective, so it's going to be specific to determine. So those are the words, like when you are writing your dissertation, those are the kind of terms you use. And that's the same thing for a clinical audit. And then you select a standard criteria. So if there are local guidelines, that have already been, authenticated, you can go for that. And you can also go for international guidelines. So locally, we have the SOGIN, which is the Society of Gastroenterology and Hepatology in Nigeria. So we also have our guideline, but our guideline, of course, is not different from the international one. So the European Association for the Study of Liver, the ISO criteria, we have the AASLD criteria, these are all standard guidelines that you can adopt in managing patients with upper GI bleeding. So you have to be familiar with these guidelines and what they say, Then the next step is to measure performance. So before you do that, you have to observe what your current practice is. And then you fashion out a proforma or a questionnaire to gather information on what you currently do. So this would be the proforma should cover the knowledge of the signs and symptoms of upper GI bleeding, the skills in resuscitation, availability of resuscitation drugs and equipment, adequacy of medical and nursing staff, the adequacy of blood products in the blood bank, availability of endoscopy services. So this tells you, are we dealing with, are we going to go more for a structure or a process, to help us, which of the areas. Then with that, you compare. So getting this information now, you are now going to compare this with the criteria and the standard. Then the next is to make improvements. So if we are going in the line of process, you are now going to be training the healthcare professionals on the identification of the signs and symptoms of upper GI bleeding and resuscitation, because that's actually a very big gap. We've had people who would see patients, admit patients with blood pressure of 70/30, and they'll just be walking. Maybe because the patient is still talking, they don't know that this patient is already in shock, and no protocol is on ground to immediately call the blood bank or to start to set white ball cannula and at least start to give crystalloids while you're grouping and cross-matching. So this is one of the high causes of mortality in patients with upper GI bleeding. Then are there adequate blood products in the blood bank? And then do we have upper GI bleeding resuscitation medications, vis-a-vis the proton pump inhibitors, vasopressors, crystalloids and blood products, and then the ICU, is it equipped, because of the ABC of resuscitation. If the patient is not breathing, you have to take over the respiration. And then, is there a well-written guideline on the management of upper GI bleeding that's already pasted in the emergency room that is accessible to everybody, so everybody knows the protocol? Once a patient comes with upper GI bleeding, these are the steps we should follow, and there must be somebody, when you are making improvements, there must be somebody that has been nominated in this group to oversee that all these steps are being carried out, and then you set up a target with a timeline that within this period, let us see how many people that will come in with upper GI bleeding that we are going to be able to save with this improvement in our services. So you set a target, at least 80 to 90% of patients that are coming in with upper GI bleeding, should survive. And the last will be to sustain improvement. So you have to ensure that all the relevant stakeholders are carried along with the necessary changes. Then you give timelines to see that there's an improvement in your mortality rates, and then in sustaining improvements, you also identify your shortfalls and come up with your policy documents. And then if you see that you are still not meeting up targets, then you now have to give another time for a re-audit, where you're now going to be looking at another aspect of the component of clinical audit. So this is how clinical audit is carried out. So it is specific, it is measurable, it's achievable, it's realistic, and it is time-bound. Thank you very much.
Thank you very much, ma. We really appreciate. Yes, we really appreciate.
You're welcome.
Your wonderful contribution, ma. Thank you very much, ma. We hope to see more of that, ma. Thank you, ma.
Dr. Yaya, Dr.
Yes,
Abu
ma.
can present. You don't have that time. Let Dr. Abu present, but she keeps submitting slides.
Okay, ma.
Thank you. Okay. Okay, ma. Thank you. Thank you, ma. Good morning, everyone. Let me just quickly run through. So my question is question 1 for the November 2020. Question 1 is define a team. Now, a team is a group of people with complementary skills, age, and expertise that is organized to work together towards a common goal. So the keywords here is a team is a group of people with complementary skills, knowledge, and expertise that are organized to work together towards a common goal. That's the definition of a team. Now, questions 2 is list 6 examples of teams. I'm going to use the hospital. So in the hospital setting, we have the infection control team, example team, medical emergency response team, disaster management team, stroke unit team, coronary care unit team. These are examples of teams. Now, question 3 says list 4 barriers to teamwork. Some of the barriers include lack of trust, poor communication, personality conflicts, negative attitude to work, inadequate resources or poor resources, unclear goals, and poor leadership skills. Question 4 says list 5 characteristics of a good team. First is trustworthiness, empathy, attitude, that's the right attitude, mutual agreement, feedback. There must be good feedback system. And there should also be clear structure or clear purpose, vision, mission, and goals of the team. Of course, there should also be good conflict management protocols in place. Those are some of the characteristics of a good team. Question 5 says list 5 components of teamwork. Components of teamwork include 1, communication. There should be good communication, for a team to function very well. Good communication forms the basis of a successful teamwork. and one of the most crucial elements of teamwork. Commitment is also essential, that all individuals are willing to commit to the team's purpose and mission. Respect for each other, delegation, interdependence, adaptability, and then clear plans for the team. These are some of the components of teamwork. That's the end of my presentation. I just answered the question. So if recommendations, inputs are welcome, sir. Thank you.
Okay, thank you very much, Dr. Agu. Thank you. I think the floor is open for comments, additions, and clarifications. Thank you. Any comments, please, before our teachers come in? I think just want to add that. Okay, Dr. Oladimeji, you can go ahead, please.
Thank you, sir. So I just wanted to see a slide on the differences between, because that's the question they usually ask, clinical audit and research. I know you gave a slide on that. I just want to quickly see something. You can pull up the slide if it's possible, but if not, no worries.
Okay, thank you. I think you had a slide for that. Maybe after incorporating what our teacher said, maybe he'll post the slides.
Dr. Yaya, this is our prof, the grandfather of the group. Prof, sir, good morning, sir.
Good morning, sir.
He's very humble, don't worry.
Yes, sir.
Sorry, hope I'm not holding the team back.
Not at all, sir. I think if the person can put up the slides again, and then we'll just go to that particular one, because it's a very common question. And if Prof had identified the problem there, then it's something we need to look at immediately.
Chief,
Okay,
he didn't have slides. He doesn't have slides.
No, for the presenter.
No, the first speaker, not the second one.
Okay. Doctor Dahatu, please help us. Just put it up again.
As Dr. Shitu said, it's a very common question in the exam. Differences between clinical audit and research. Okay, so it is not possible, so I won't delay the team. Okay. All right. So you can see that the content here is a little bit sketchy, because all you're just writing is focus, output, funding. That's in fact, this might not even be in the marking scheme. So you need to know what is in the marking scheme. Okay. So for research now, number one, see, the easiest way to remember is just look at the way you did your dissertation. All those different aspects of a dissertation, most of them are not in clinical audits. Okay. So we start with hypothesis. For research, yes, there will be hypothesis because we are doing some form of experiments. Either it's an experiment to see is a constitutional study or interventional study, but it's a form of experiment. You're trying to differentiate between a new study, a new intervention compared to previous standards. That is what you are trying to aim at a research. You want to find out new things, right? So, but in a clinical audit, you just want to look at the outcome or how you make an improvement on your existing standard, comparing your standard to whatever you are practicing to a well-established standard, okay? one other important thing. So that brings to the fact that in the research, you're going to use hypothesis. But in clinical audit, there is no hypothesis. Okay? In a research, when you get to the methodology part, there is a place where you talk about getting sample size, right? Sampling technique, sample size. In clinical audit, you won't do all that. Just trying to, because you are trying to streamline the salient differences between research and audit. The things you will do in a research, which you will not necessarily do in an audit, that is what the question is focusing on. Okay? In a research, you need ethical approval. In clinical audit, you don't need ethical approval to carry it out. But if you want to publish it, you might need a ethical approval. If you want to publish in a journal. But if it's a content of your in-house hospital, you don't need the ethical approval. But for a research, you need ethical approval for enrollment. Okay? As I said, in clinical audit, you don't need all that. So they're just bottom. I'll just need you to go again back to your research dissertation work and see what you do there and compare it to what a clinical audit is. Okay? In a research, for example, you will have to determine the method of research. Is it a cross-sectional? Is it a randomized control trial? Is it a cohort study? All that is a content of research. In clinical audit, that is not there. Okay? So I just need to just, so rather saying funding is by grant is minimal, it doesn't actually make a difference. Please, your research dissertation is very important. Thank you. I don't know if Dr. Shitu can add more to it, but I think there are some streamlined differences.
I think so. Just to also add is that for you to have a clinical audit done, you must compare to a certain standard. You must compare whatever you're doing to a certain standard. But in a research, you don't really have to, per se. So you don't always have to compare to a standard when you're doing a research. But part of the process of doing the clinical audit involves comparing to a standard. But I think you've covered most of the differences of it. And then the process of an audit, you need to go back and see what you've done and make changes and see what you've done and then, sustain that improvement and all of that. In the research, depending on the parameters of the research, you may not have to go back. All you have to do is complete the parameters as stated in your methodology. Then that's that. Okay, but in the clinical audit, you have to go back and look at what you've done and, of course, continue the process of quality improvement. Yes, so I think those are the other ones that I would have wanted. But well done, Prof. Yes, sir.
Yes, sir. Emphasizing your last point, in clinical audit, they go and re-audit and re-audit. But in a research, all you do is complete the research and give recommendation. It ends there. But in clinical audits, whatever you have found that as your lines of recommendation, you implement it, then you audit it again and re-audit it again to be sure that everything is being done. Okay. Thank you, sir.
Thank you, sir, for the comment. So this table, I direct copy it from the lecture given by Prof. Ogoni. It's just that's how he differentiate between clinical audit and research. Just copy and paste. Thank you.
It is good to look at what they give you at the update courses and all of that. But sometimes what you're given in the update course may not be enough to answer the question as it is. Usually things like clinical audits and the rest, they usually call in community health physicians to come and put us through it in the updates many a time. But yes, it's a slide from the update, but does not mean that they give you everything. The idea is that you're going to go and add more to it and follow it up. Okay, so some of the things here, it's not like everything here is wrong, no. Okay, many of the things here are in order, but at the same time, you need to add a little more substance to it. Particularly, they may be working with a different yardstick from what what was presented at the update course itself. So we need to take that into consideration as well.
Thank you very much, sir. Thank you, Prof, sir, for the contribution.
Dr. Yaya.
Yes,
thank you, Prof, for the contribution. Dr. Chitu, thank you so much. For the presenter, Dr. Dahatu, this is not to say you didn't do well, you did well. They are adding more. Look at the way the angle Prof came from. If you go for exam, you might not remember all that you presented. But if you use this, the way you went through it with dissertation and the rest, you remember some of those things from the dissertation, you remember what you presented. That's imagine they ask you for, because exam and update are two different things, really. Maybe ask you up to 510, and you have like 3 in your update. So that's one thing I noticed with national. Sometimes they always give you less, and the exam they require more. So it's good to have as much examples, as much differences as possible, so that irrespective of the number they ask you, you are fine. So that's that. Thank you so much. We appreciate Prof and the presenter. Thank you.
Thank you, ma'am. I just want to add from the second presenter about the team. Just to have in mind that there is an acronym for team again, apart from the one you mentioned: trustworthiness, empathy, attitude, mutual agreement. Again, team stands for together everyone achieve more, meaning emphasizing the need for coming together with complementary skills, working together to achieve a goal. Thank you. I don't know whether we have time for another one. We can.
No, we don't have time. I wanted to call on Fatima, so I've not heard her voice. Let her just say something on teams. I wasn't so satisfied with the presenter's definition of team. I don't know where I got it from, but I wasn't so satisfied. But Fatima, can you just make some comments?
Yes, Ma, thank you very much. My comment is regarding the clinical audit. And I think regarding the measurement of the performance, after you collect your data, you compare with the standard criteria, that is the national guideline, as Chief Kuki rightly mentioned. This is where when you compare, you measure, are you up to 30%? No, are you up to 40% of what is in the standard? So when, after you implement the change, you also assign a supervision of that change, because things may not just go the way you like it. So by assigning supervision, it will ensure that all those changes are being implemented, and the doctors, nurses, or whoever are following those changes that you implement. So you allow time like 6 months, 1 year, to ensure the changes have occurred. Then you re-audit. When you re-audit, you'll find that you measure the performance again, where there may be improvement up to like 60, 70%. So that is telling you that you are actually doing good. So I think that's what I had in addition to what was mentioned. Thank you.
Thank you, Dr. Fatima. Thank you so much. I don't know if any of our facilitators have any comments on the team, the presentation of team. Okay, it seems we are all good. So thank you.
I think, Dr. Christopher, I think it's important that all the participants here look through that that guideline paper by National, okay, that tells us about how to go about each of these things. I think there's a little bit more about teamwork in that guideline. I can't
yes,
remember.
There is.
It's been a while since I looked at it myself.
There is.
Yes.
That's what that
because apart from
Yaya
communication and education, exactly. I think there are more components to it. I think there's leadership, there's There's some other things in teamwork, okay, apart from the things that was put forward by the presenter. So I would want us to look through that guideline. I'm sure it is somewhere on the group, whether we can repost it so that everybody can have a copy of it if they don't have one already, so they can use that as the yardstick. Questions like teamwork, when they ask you direct questions like this particular question, then they're helping you guys, because all you have to do is pour out whatever is in the guideline back, okay? But many a times it's an applied question they will put forward. They may give you a scenario and ask you to put together a team, and then you have to mention all the components of that particular team. Or they could, come up with a clinical scenario of how a patient is being managed and how you can improve that by forming a multidisciplinary team or something. Okay, so usually that's how it tends to come, but this time around they just ask the question direct, which is, I think it was supposed to be a bonus, so to speak. So please, let's all look to that guideline. So in case they throw a bonus like this, then it's easy to just get your full mark.
Thank you, sir.
Thank you, sir. We really appreciate, sir.
And in addition, please, I'm begging the class to please, whatever it is, just try and project something. Without projecting the slides, it may not be easy to even remember the question, talk less of people commenting on it. So please, whatever it is, even if it's not much, just project at least, no matter how few the slides are, at least we can even look at the question. But without the question, people may not be able to remember what exactly is being asked, talk less of commenting. Thank you.
Thank you, Chief.
Thank you.
Fatima.
Thank you.
Thank you.
Dr. Fatima. Dr. Ago, please. Is here on that presentation, so start now. So thank you, the presenter, Dr. Dahato, Dr. Ago, then our class chair, Dr. Yahaya. Thank you so much. I appreciate you all. Our teachers, Prof, for coming. Thank you so much, sir. Always appreciate your input, your wisdom. Thank you so much. Chief Cookie, Chief Chitu, Chief Bansi, Chief Remigu, Chief Manza, Dr. Kopi, Dr. Fatima. Thank you all for coming to class. I appreciate you. I don't know, I think Chief Chitu, Chief Prof will just make some comments and we'll close the class.